Earlier this month, the Value Initiative hosted an AHA Executive Forum in Atlanta, where hospital and health system leaders shared insights and explored opportunities to address value and affordability in healthcare. The forum explored a variety of topics, but one theme resonated strongly throughout the day: collaboration. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hetterly, senior writer at AHA and your podcast host. In this episode of Advancing Health, Dr. Melinda Estes, President and CEO of St. Luke's Health System and Chair-elect of the AHA Board of Trustees, moderated a panel that discussed the importance of creating partnerships to improve community health. Panelists included Benita Burt, President and CEO of Mississippi Urban League, Rick Foster, Executive Director of the Alliance for a Healthier South Carolina, and Maria Pinzon, Executive Director of the Hispanic Services Council. Their discussion explored the role community partners can play and potential ways hospitals and health systems can improve the overall health of a community by collaborating with them.
We have our next awesome panelist coming up. I'd like to welcome back Dr. Mindy Estes. And as she comes up, she is going to be moderating a panel called Reaching Outside of the H to Improve Community Health. And I believe Dr. Estes is going to introduce the panelists. So thank you very much.
Absolutely. Come on up.
I don't know how dramatic you were going to make this.
Well, I can make it as dramatic as you would like. How are you? Nice to see you. Thank you. I'll put the three of you down there.
Okay.
Stay up here. I like this.
They're pretty nice chairs for those of you who are getting a little restless out there. Well, it's my pleasure this morning to moderate what I think will be a very interesting panel. This panel is going to explore the unique partnerships that hospitals and health systems and community organizations are forming to improve the health of the community. As we all know, managing and improving the health of a community isn't achieved by hospitals alone, although we also know it has taken us in the hospital world quite a while to understand that we can't go it alone. And this panel is going to discuss and explore the role of community partners and potential ways that they can impact the status of community by helping hospitals and health systems extend beyond the four walls of the hospital. And of course, today, we used to talk about healthcare, but really today, fortunately, we're talking about health in all of its facets and aspects. So we're very fortunate, and I think it's one of the strengths of AHA that when we have a topic, we can reach out around the country and really bring in folks who have great wisdom and great knowledge and great success to share with us this morning. So let me introduce our three panelists, and then I will ask a few questions. And as always, I will save some time at the end for your questions as well. Benita Burt is the President and CEO of the Mississippi Urban League in Jackson, Mississippi. Dr. Rick Foster, sitting right here, is the Executive Director of the Alliance for a Healthier South Carolina and Senior Advisor to the South Carolina Hospital Association in Columbia. And Maria Pinzon is the Executive Director of the Hispanic Services Council in Tampa, Florida. And since we are here in Atlanta, it is no accident that we have three people from this region who are doing exactly what we are talking about today. So I will start with a couple of questions, and the first one is for both Benita and Maria, and I'll let you two decide who starts. The question really is sort of twofold. One is, how are you partnering with healthcare providers and associations within your communities to enhance community health? And the corollary then is, what are the keys for successful partnerships with healthcare provider organizations?
Okay, well, thank you. First of all, thank you very much for this invitation. I looked at the agenda when I was asked to participate, and I thought it was one of the most important ones that we can be talking about, particularly from the perspective of a community-based organization. So we are partnering with a number of folks in Jackson, Mississippi to think about and to enhance community health. One of which is actually the University of Mississippi Medical Center. That's the largest, the only academic health center in Mississippi. And so our work is to try to improve the community's health. So it made sense to partner with a university. And in doing so, we have partnered with them to develop a culture of breastfeeding among young African American women in Jackson. Because we know the uptake in breastfeeding, but we also are looking at the economic cost involved in raising babies. So mommy's milk is the best milk, and it is free if you do it right. And so we encourage young women to do this, and of course, we can only do it in partnership with the university. And so the medical center helped to set up a baby cafe in which you have these young women, but they provide a lactation specialist. And so collectively, you have a group of women sitting around really supporting themselves in a community setting with a professional, and you really do get different kinds of responses to questions and different kinds of questions because they're in a community setting. And from that, we pushed out a clinic in the local high school. Little controversial because we were talking about breastfeeding. They thought we were promoting sex, but but the idea behind it is to really try to make the community as healthy as it can be. And so when you look realistically at what you have in school systems, then you need to be able to address it. And so we get referrals from the Department of Health, from their WIC moms, women, infants, and children, who get WIC and don't use it properly. So a part of our work is to make sure that you not only use it, you don't trade it, but we have a facility where we actually teach you how to use it properly as a part of the whole process of getting women from breastfeeding to eating healthier, to cooking healthier, as a part of the entire regime. Okay.
Perfect.
Oh, and the other one was the successful partnerships with what are the keys? Well, you know, I think that the keys are really developing a level of trust. You know, if you do not have a level of trust from communities, from hospitals, you can come to community meetings and you will get polite applause. And when you leave, that's when the actual meeting will happen. So you have to really, you can't visit once and then come in and say, I need you to do this survey. Community people have to know you. Just like any other thing, they have to let you in. And once you are in, they know that you're not extracting something from the community for a professorial report or for some other thing that you are doing, and that you are going to provide them with feedback as to what you got, what you plan to do with it, and how does it benefit the community. One thing that we learned early on was the essence and the real application of community-based participatory research. We understood after a year of having someone from the University of North Carolina at Chapel Hill in the Maternal and Child Health Division talk about the roles of community and how you ought to lead and how there ought to be shared responsibilities. And so with that kind of background and just an indigenous community group, we decided to proactively do something about health. And then other partners came on as we were doing that. And you know, you can feel fuzzy and know you did something, but there's got to be an evaluation methodology to it that you got to be able to show, you got to be able to quantify that it not only felt good, but here's how it worked. And I know it worked or didn't work, because in some instances it doesn't. But at least you know where you are and you are able to recalculate and then to go back and do better. But the essence of it, I think, is to have those partners, non-traditional partners, and you guys are non-traditional partners in the health field, particularly when you're talking about hospitals and a community-based organization sitting around the table talking about how to promote health. That's very different, because normally community people go to you, you give them something for their ailment, and they go back home, and they may see you next week, and you have no idea of why they're back. But if a community organization that you trusted and know, you can call them up, Benita, you know, we have this going on in the community. Any ideas? Well, you know, we convene people. We don't have focus group, we have community conversation, because people are a little hesitant about focus groups, quote unquote, because they think that's something different. But when you have a community conversation and then you come to the meeting, you are in. You can come back many, many times and get most of what you want from the community. So partnerships are just essential.
Thank you. So Maria, what's going on in Tampa?
Buenos dias. So I'm here to tell you a little bit about the Latino community perspective, and particularly it's a new community to Tampa or to the country, limited English speaking, mixed status families, and the difficulty of integrating the community into systems in general, and in our role as facilitators and navigators. And I think the first, when we started our organization, we started precisely to be that link between the non-Spanish speaking social services and health systems and the non-English speaking Latino community. And we were there to provide questions. And when they related on several fronts, from how do I find employment? Where do I learn English? I don't understand my hospital bill. Why do I owe so much? I need to understand what this letter about my child is from school. Why can't he go back to school? So we were dealing with a lot of issues that may not be in the health centered world, but they related to the health, the physical, the emotional, and the mental health of our community. So we began to do, we understood that we knew that we had the trust of the community to be able to give them the right answers in Spanish. We understood the immigrant experience. We're all immigrants at our agency, so we understood the difficulty of learning the language, integrating. We also knew that the providers were looking at us. They were seeing, oh my gosh, where did all this Hispanic community, well, where did they come from? I don't understand. And they were calling those individuals who spoke Spanish in the 26th floor. Hey, we got somebody here that doesn't speak Spanish, that doesn't speak English. Can you help us out? And we were saying, how could this be? We're in Tampa. We were funded by Cubans, by Spanish. What do you mean you don't have anybody? And so we were seeing, and they were very proud to tell us, mental health centers would call us and say, we're excited. We got our Spanish-speaking psychiatrist. Great, wonderful. But do you have someone in the front desk, a receptionist, the person who answers the call? Do they speak Spanish? Oh, no. Okay, so how will they get to that great Spanish-speaking psychiatrist? So we began working with providers to look at helping them understand our community, the cultural competency aspect, why we talk with our hands, how we use our eyes and our mouths to communicate, why when you ask Mrs. Hernandez to come to the visit, why she brings her mom, her husband, her grandparent, why your hospital waiting room might not be as big as you thought it needed to be. And so we were beginning to look at those aspects. We were hearing from our community that that they felt that they were rushed through a process. We do like to talk. So the idea that came up about increasing physicians' visits is one that culturally ties into our community and the need to talk and to do so. So what we saw was that even though we were boots on the ground, we needed bigger boots on the ground, and we began a community health worker program, or a promotora program, that are individuals. In this case, right now, they're all women, but they are who live in the community, understand their community, know the social service providers in that area. But they were that link to those health systems. And that for me, the health system includes the food banks. They include the clinics. They include the schools where our community is at. So these community health workers were trained to not only do needs assessments. So the community health, the CHNAs that the hospitals provides sometimes don't reach our community at all. So we began to look at what are the needs of our community, and we were seeing that our incidences of high blood pressure, diabetes were continuing to grow, and how can we knew that we couldn't necessarily directly impact the difference in diabetes, but we could have a chance to work with our partners to decrease some of that. So we began offering at faith-based organizations, through the food banks, through the clinics in particular. We began to offer, for example, Cooking Matters 8-week or 12-week cooking classes, where we began to help people understand, one, not only how to cook more healthy and nutritionally, but also to help them also understand how to navigate the health system where there might not be Spanish speakers at all. And we began to see great results in utilization. We also are working with a community that is underinsured or uninsured. So we were helping them. We began to provide application assistance to not only SNAP benefits, but also to the indigent health care plan that our county offers, and we were being able to connect more employees. So we were dealing with the social determinants of health that I think are beginning to show signs of promise in terms of the overall health of our community and integrating them into the society as a whole. And I would just have to echo Benita that trust is key, and understanding that the definition of health for our community may be different than your definition of health, but it must be valued and respected. Many times we hear, Latinos don't care about health, they don't care about education. And what we're seeing, I need to remind you that when we sneeze, the first thing we say, we don't say God bless you, we say salud, health. When you do the toast a drink, we don't say cheers, we say salud, health again. So it's a central part of who we are is health, and we have our own values, and I stress that sensitivity, that valuing, and that acknowledgement that our health traditions and beliefs are key to the care that needs to be provided for our community.
Could I ask a quick question? I'm curious, because while this is fresh, what you just heard, how many of you that were with health systems either employ community health workers or work with a partner organization to provide community health workers in the community? So about maybe a third, maybe a little bit more than a third. That's good. I'm encouraged it was that many hands up. That's good.
Well, I'm going to turn to you now.
Okay.
And the Alliance for Healthier South Carolina has more than 50 organizations that work together. So how have you brought all those organizations together, aligned the vision, and what are the takeaways?
Well, let me start. Well, first, I'm thrilled to be here with the rest of the panelists. This has been a wonderful session already. So I came to the Hospital Association 12 and a half years ago. I was chief medical officer at a multi-hospital system prior to that, and I was brought on initially to focus on creating a statewide program for quality and patient safety, working with all the hospitals in the state. And over the 3, 4, 5-year period, we saw some great improvements in the key metrics around quality and safety, especially in the hospital setting. But a number of our leaders, including Bruce Bailey sitting there that spoke earlier, noticed that, this is all wonderful, but we're still fighting Mississippi and these other southern states to not be the 50th unhealthiest state in the country. It's the wrong thing to be competing with. You know,
It is.
Yeah. As a big sports fan, I like to compete for who's going to be first, try not to be last. And so the leaders basically from the health system said, we need to be doing something more than just focusing on health care and what happens for sick care in the system. And that was the precursor to the Alliance for a Healthier South Carolina that now has actually over 60 members. It's a state-level collective impact-based coalition that is focusing on how we align our work to improve the health and well-being of everybody in South Carolina. And there's several things I want to challenge the audience on that I think are relevant to where we've had success. One is getting you as healthcare leaders, along with other healthcare leaders, to change from looking at health in the context of health care to health care in the context of health. And you think that's not a lot of difference, but that's a cultural, behavioral, even business mindset difference. Then the second would be, and something relevant to what you've heard, is getting comfortable working with other community partners to make upstream investments in efforts that actually will work to improve health and allow you to be more effective in providing health care. So the concept of providing universal access to preventive care that was mentioned from Dr. Rubin is the idea of doing that. Now, I'd like for it to be done for more than just those who have employer insurance, is an example of an upstream solution, along with efforts like engaging community health workers and working on housing and other factors that can come into play. The third part of that is relevant to our discussion about innovation, and I'm already thrilled we've had this discussion, and we've seen this with our work with the Alliance, is making sure you're matching your commitment to high-tech, low-touch innovations, which are important, with low-tech, high-touch innovations. And so to invest, which is wonderful, in being able to have the technology to do home monitoring, for some patients will work, but we know from our work in South Carolina and sounds like in Tampa as examples, sometimes you need to have someone go into the home and interact with that person, especially if they're by themselves. So they're in social isolation. They may or may not have that daughter or somebody else, and making that connection can make all the difference. And so what we found is that there's a way for us to bring together partners. And we got 8 different sectors that are part of the Alliance: the healthcare systems, the universities, the government agencies, but also consumer-based groups and community-based groups side by side with equal voice. And now what we're doing is connecting to community coalitions across the state where our health systems are important anchors to that, but they're not working alone. They're working with other partners. And then the last thing I want to say as far as the opening comments, to me the most important 4-letter word in this effort is with. All of you over the years, and it's still important, have done amazing things to and for the communities you serve. Doing things with the community is a different approach. That's where you actually sit down with community leaders and those who have lived experience and most affected by the social determinants and social drivers of health, and asking them what they want, what they feel like they need. A great example we had in Spartanburg, which has been one of our champion communities as far as trying to move the bar on overall health. They went to one community. To their credit, they were planning on putting a new facility there for outpatient care because they knew that's what they needed. They sat down with the people in the community and they said, well, if we can pick one thing first, we'll pick more green space. We'd like to actually be able to get out and be safe to go around the community with our families and get exercise and activity. They did that first, and then they did the other actions. And I think they were able to engage the community in a different way because they actually listened to them, and it actually required less initial investment to do the green space work.
Well said. For all 3 of you, what are your greatest successes to date, and how do you sustain these partnerships over time?
Well, I guess I'd point out an initiative that was really started by the community itself in an area of Jackson where people were concerned about, community members were concerned about their own health, and decided to form a community steering committee to think about how it could happen. And so community members, with help from a local professor there at Jackson State University, decided to ask the community questions about his health. And so the question was, why is it that African Americans get sicker and die sooner than other groups of people, given the fact that we all go to buffets, eat 2 meals at one time, eat 2 desserts at one time. So you're essentially having 2 meals at one time, right? So why is it that African Americans get sicker and die sooner than other groups of people given the same situation? And so we asked a group of folks who were from economically advantaged groups, economically disadvantaged groups, to see what the differences would be. So the economically advantaged group said, well, you know, these people just won't get off their behinds and exercise. They eat too much. They don't go to their parks. They don't have, they won't eat properly. They don't know the kinds of foods to eat. And so that's why they're just basically lazy. So the economically disadvantaged group said, I'm afraid to walk in my neighborhood. There are no streets actually to walk on. I can't let my kids go outside. When I leave the school cafeteria, I'm going to another job at the hospital in food service. And when I return, I'm going to help little Johnny with homework if I can help. And if I can't help little Johnny with homework, I'm going to have to find somebody else who can do it. And so there is no time for us to do the kinds of things that keeps us healthy. And so we decided to, well, let's figure out how we can develop some interventions around that to try to figure out how we can help the community. And so what we did is that we, with those answers that we got from across the community, we developed concept maps. And we asked the community, these concept maps depicted what was most important to the community. And then based upon those concept maps, we developed the interventions. And so the one thing that came out of it is that there needed to be a facility, a fitness facility that is affordable, that is in the neighborhood, that is welcoming and that is safe. And so long story short, we saw a shuttered grocery store that had been shuttered for about 10 years, really. And today it is Mississippi Urban League state-of-the-art facility in which there is a community gym. There is a fitness center for children with functional equipment. There is a prenatal program for moms. There is a healthy cooking class for folks to be able to eat healthier. And so what the community did really was to decide what it needed, and then we got partners to help us do it. And so now there is a level of sustainability so that if I walk away, it doesn't matter, it's there. And it's going to be there for the community. So many of the things, I look at that as a major success of our work because things that are put into community, initiated by community, will remain in the community, regardless of changes in leadership or whatever. The other thing that I would point to that we're pretty proud of is that there's a clinic that looks at social determinants of health. Dr. Bettina Beach at UMM's University of Mississippi Medical Center. And then there is the Mississippi Food Network, which is a food bank. So we had people coming into our gym who obviously were hungry. Dr. Beach had people coming to her clinic who were hungry. And some of the issues around health had to do with food as opposed to being sick. They were sick because they did not have proper food. Long story short, we now have a food pantry where Dr. Beach sends us referrals from her clinic and we fill the food prescription for patients who come over. And so we decided that we needed to open it up for the entire community. So we opened up one day, 200 people came. We have not advertised. We have not done anything except word of mouth spread that the Urban League had a food pantry in connection with the Mississippi Food Network and UMMC Medical Center. We are so pleased with that. And I'll tell you one funny thing. You know, when you work with food banks, there are staples in the food bank packages. And so there's something called split peas, okay? So most of the folks who got the packages had no clue as to what split peas were. And so one woman said, she said, you know, this bag is really heavy. I don't know what this stuff is, so here you go. So she gave it back to me. So what I decided to do, well, you know, we're going to staple, this is the staple in the Food Network distribution. So the next time they came, I had a chef to come out and cook split pea soup. And we had tastings as people were getting their distribution packages. They were able, like, oh, this is what this tastes like. And in each bag, there was a recipe for them to be able to cook it. So those are just examples of thinking about, you know, the next obvious thing. We try to look beyond the obvious and see the next things that helps the community. And that one woman who gave her peas back has since said that she not only uses them, but she has told her daughter and other people how to use them. So that's something that we continuously see as helping the community improve its health and to sustain itself.
Thank you.
Wow, I feel like I'm in Tampa when you talk about that. It is amazing how these are just the simple solutions that are key. But like Benita was saying, you know, we have, I can tell you of different successes. Of course, the first one we like to say is that, you know, that we have a group of, at this point, 10 women who before had no work, had no professional development, and we've grown a group of women to believe in themselves, to believe in their knowledge, and to know that they can help a community get healthier. For us, that's the greatest success, and we're continuing to recruit. We also have the trust not only of the community, which we've always had, but the trust of the partners. So like Benita and her community, we have the food pantries, and we were seeing a great waste of food. So now we are able to, and primarily because they didn't know what to do with the food that they were getting, or it didn't fit. Macaroni and cheese, Latinos don't tend to eat that, you know, but sort of how to do it, and it necessarily not healthy. So we would get what they would be getting in the bags or in their weekly allotment of food, and prepare a healthy meal, create a healthy recipe, cook it on the day of the distribution, and be able to provide those tastings. What we have seen then is the word of mouth, to be able to then increase the idea of how to cook more healthy. More importantly, it continues with our mission of integrating an immigrant community into the United States to be more successful. We work with the veggie van from the YMCA so that they would be able to get more clients to come and receive the bag of veggies and fruits which they weren't getting before. So the promotoras were key in being able to do that. Our cooking classes have also shown great results. So we have, of the participants, we had 98% of the participants indicated an improvement in their eating habits. 61% indicated an increase in their confidence of making healthier dietary decisions. We had 70% of the individuals who expressed that they had anxiety state that they had improved, that they had reduced their anxiety based on the cooking classes and the networks of mutual support that were part of these cooking classes, meeting other people, recognizing their struggles in the United States. You know, regardless of where you stand politically, there is right now is a very difficult time for the immigrant community where there's great fear. So we're seeing a lack of utilization of hospitals, of reporting crimes to the local authorities. So this is a time for them to come together and express that. So that has definitely reduced anxiety. We've also seen 86% of our participants saying that who expressed that they had mental health issues outside of anxiety, that they felt an improvement in their not only mental health, but their trust and their connectedness to their community. That I think that may not be of great consequence to the healthcare delivery and how you measure, but in terms of population health and a community that is sometimes forgotten because they may not speak English, because they are undocumented or documented, because they don't utilize the healthcare system, that this is a great opportunity. There, you know, in Hillsborough County, where Tampa is, we are 30% of the community. So if we increase the health, if we improve the quality of life and improve the quality of health of that community, the whole community benefits. It's just clear. So it's how to get that message to our partners that is what this is about. Together we can do it all. And you know, I'm part of a community health needs assessment advisory force for or task force for one of our hospitals in the area. And then we're talking about the response to a need to having an exercise class. I think it was the lack of exercise for the community. So I said, and they were just talking just great things about it. And I asked, are you offering this in Spanish? And the answer to me was, well, 50% of our workforce is bilingual, so we're taking care of that. Let me ask you again. Is that course, 6-week course, offered in Spanish? And there is a difference between offering a course and a class in Spanish than saying to me that you have 50% of your workforce is bilingual. It isn't the same. It's about offering that tailored class. And I think for us, the success is having those partners understand that and asking us to cooperate with them.
Thank you. You know, I knew when we put this panel together that we would have no shortage of things to talk about. And Rick, I'm going to give you the last word here.
All right, I'm going to do rapid fire. Because, I mean, I'm going to look at it starting out at 20,000 feet. So the alliance, as far as what we've been able to accomplish, is by bringing leaders together from all these different sectors, is more at the policy level in the sense that we have been able to, for the first time ever in South Carolina, have a state health improvement plan under the name Live Healthy South Carolina. We partner with our partner of health. We never had a true state health improvement plan. We are now trying to make sure, and we've gotten both the governor and our legislature to endorse that, and you think that may not be a lot, but you live in a southern conservative state. The fact that we're even acknowledging that in that plan it talks about equity and the racial and gaps as far as health is a big first step. We now are working on an equity action plan for our state. At the next level down, there's work like with our birth outcomes initiative. I heard about centering pregnancy. We have the most hospitals in the country that are now baby friendly, so we have the highest percentage of women being born in hospitals that are focused on promoting breastfeeding. We have a milk bank. There are a number of things we've done. The Healthy Start program I mentioned earlier with community health workers. We're now doing that for child health and well-being on the behavioral health side. We've got a group working at the coalition's approach to improving access to mental health care in the primary care setting, but also deal with substance use disorder problems from a more global perspective and a community-based perspective. And now we're working, like I said earlier, with a growing number of community coalitions where the health systems are serving as anchor with other partners to both develop their own local and regional health improvement plans, but to get into some of these specific upstream solutions. And don't have time today, but I mean, I could list those. It's everything from creating healthy food environments to helping with housing situations, to identifying those populations that may be at risk. I think about asthma, pediatric asthma. I'm a family physician. I could be the best doctor for treating asthma, but if a majority of my patients are living in homes with mold and smokers and other factors, there's not enough medicine I'm going to be able to give them to control their asthma. And we've got to realize that's where we're not making the investments that we need to be able to make. We also have employment opportunity programs that hospitals are doing. I mentioned to the group at our table, one of our hospital systems, when they built their children's hospital, which is almost finished, they made a commitment that at least 30% of those involved in building that had to be minority-owned businesses. That has led to a minority-owned business now will control all coordination of all building projects they have, not just in Charleston, but statewide. So those are things, when you start adding them up, provide economic benefits to high-risk populations, but are also providing value to the health system. So I think that's where we're trying to get to, is understanding that if we don't move upstream and we don't look at the work we're doing through an equity lens, be honest with you, South Carolina will continue to fight with Mississippi and Louisiana and the other southern states to not be last. And if we're going to ever get out of the 40s, we're going to have to close those gaps and be able to do it both at the policy level and the programmatic level. And we're seeing progress being made, and I'm encouraged by these types of sessions where health system leaders are in the room to have this discussion with other important partners.
May I just say one thing to our hospitals from a community-based perspective? We really need you. We really need your help in the community to help us help our patients and our families and our community members, rather, to be healthy. We really do. So we invite you to invite us to sit on your community advisory boards. When you're having issues that you need, call us. You know, one of the things that a university can do is bring your medical students to our facility. There's a professor at the University of Mississippi Medical Center who brings his med kids in. I shouldn't call them kids, medical students in to community to just really kind of get what the sense of that is, what it means to be in community. And they go away just absolutely amazed. And they're right up the street from us. And we don't know each other. So if we don't know each other, we will never get the best from each other. Thank you.
You know, I appreciate our panelists. I moderate a fair amount for AHA, and I will tell you it's easy to moderate when you have people who are experts and are passionate about what you do. And certainly, you know, I always take away things from these sessions, and something that all three of you said has really resonated with me, which is listen to your community, that the community knows what the issues are and what they need from us. So thank you all. And we didn't save time for questions, but I will volunteer these folks as the rest of the day goes on, that I am certain they would be happy to interact with you and answer any questions that you might have. So join me in thanking our panelists. Appreciate it.
Thank you so much.
Yes.
Thank you all very much.
Thanks for listening. For more information on the AHA Executive Forum, visit the Value Initiative at www.aha.org/value-initiative. I'm Tom Hetterly, and this has been Advancing Health.